Hello, my name is Dr. Devinder Ramsingh. I'm Director of Perioperative Ultrasound and Clinical Research with the Department of Anesthesiology at Loma Linda Medical Center. Today I have the privilege of talking to you about perioperative point-of-care ultrasound with a focus on airway management and how point-of-care ultrasound can help facilitate the identification and localization of the endotracheal tube within the trachea. So we know that endotracheal intubation is a life-saving procedure that is routinely performed by a multitude of healthcare providers, including anesthesiologists, emergency medicine, and critical care physicians. And there are numerous techniques and technologies available that help distinguish endotracheal versus esophageal intubation. These include direct laryngoscopy via a multitude of airway devices, qualitative and quantitative assessment of end-tidal CO2, as well as other technologies that look at the anatomic differences of the esophagus versus the trachea. And so while there are a multitude of technologies that help determine endotracheal versus esophageal intubation, we are very limited to what technologies help us facilitate the appropriate location of the endotracheal tube within the trachea, particularly within a point-of-care setting. And this is of significance because it's been reported that inappropriate endotracheal tube location can be as high as 20% within the hospital. And bronchial intubation rates can be as high as 5 to 8% of all intubations. Inappropriate endotracheal tube location, again defined, shown here, as being less than 2 centimeters from the carina. Currently, the stethoscope is the primary tool we use from a point-of-care setting to evaluate the appropriate location of the endotracheal tube within the trachea, and the stethoscope has recommendations by institutions such as the American Heart Association, as well as it is the primary technique described in most anesthesiology texts to determine the appropriate endotracheal tube position within the trachea. But let's take a look at the stethoscope itself. The stethoscope was invented in 1816 by Dr. René Laennec. And while other industries have advanced with the times, the stethoscope still remains the pinnacle point-of-care examination tool for most physicians. So, comparing us to other industries, we've gone from the horse and carriage to cars that can drive themselves, from the standard notepad and pencil to tablet devices that essentially can write themselves. Yet when it comes to point-of-care examination of our patients, the stethoscope has still remained as the primary modality and technique used by most physicians. In fact, the only thing that's really changed since that 1816 time when it was invented was the addition of digital recording devices that allow you to capture the auscultation exam. Well, insert the idea of point-of-care ultrasound now as a new modality to help facilitate the physical exam process. So what is point-of-care ultrasound? Point-of-care ultrasound is defined as portable ultrasonography that is brought to the patient's bedside, and the provider not only performs the ultrasound exam, but also interprets the ultrasound imaging real time. So again, it is an exam that is both performed and interpreted by the provider at the patient's bedside. Point-of-care ultrasound should be quick and well-defined in its purpose to improve the patient's evaluation with a specific goal in mind. It should be quickly performed. Again, answering the acute care questions using ultrasound technology is the fundamental principle of point-of-care ultrasound. It is a new tool and technique to improve the way we examine our patients from the physical examination standpoint. Let me try to show you an example of how perioperative point-of-care ultrasound could be useful. So we have here a 45-year-old patient who reported a questionable history of lupus, who was scheduled for an orthopedic procedure of RIF of an ankle and distal tibia. This was secondary to a recent motor vehicle accident. The backstory behind it was that she was seen in an outside hospital, had her leg casted, but reported to be non-compliant with her non-ambulation and in the process of attempting to ambulate, she fell and further injured her ankle, and that warranted the surgical intervention that our team was requested to provide anesthesia for. However, when we began to evaluate the patient in the pre-op area, she reported that it wasn't actually that she was trying to be non-ambulatory, but she had become had worsening shortness of breath since her motor vehicle accident, and it was actually the process of her leaning over the side of her bed to improve her breathing that caused her to fall and result in her having the needed surgical procedure. So in this situation where we had no other past medical history that would sort of explain why she would be so short of breath to trigger her to have this event, we implemented the idea of point-of-care ultrasound, specifically looking at thoracic pathology to evaluate what could be a mechanism of explaining why she would be so shortness of breath since her motor vehicle accident. So we do a thoracic examination, and I'll show you the videos here. And my point, hopefully, is highlighted with this example, that point-of-care ultrasound, even if you've never looked at a picture of the heart before, you can assess that this picture is abnormal. In fact, it looks like the heart is dancing away, sort of breakdancing within this large fluid-containing space. And essentially, we were able to determine that this patient had a very large pericardial effusion. And that is the mechanism of what's causing her to have her shortness of breath. And we were able to rapidly diagnose that. Again, using the principles of point-of-care ultrasound, we approached the patient with a well-defined, purposeful examination technique and goal-directed to evaluate an acute situation with the idea of giving answers real time. And we were able to do that and ultimately have her have the intervention she needed to improve this pathology and then allow her to have her surgical procedure at a later date. But hopefully that highlights one example of how point-of-care ultrasound, particularly in the perioperative setting, could be useful. Regarding support for the use of point-of-care ultrasound, the American Medical Association has passed resolutions stating that all medical specialties have the right to use ultrasound in accordance with specialty-specific practice standards. Currently, for the specialty of anesthesiology, we are still developing and emerging the idea of how we should incorporate point-of-care ultrasound into our specific standards, or specialty-specific standards. But the approach to take this concept of point-of-care ultrasound is similar to any other technology that's been implemented to improve perioperative management. For example, technologies that now look at the arterial waveform to provide flow dynamics of cardiac output and stroke volume, or advanced anesthesia machines that now provide real-time spirometry and flow volume loops. The idea of point-of-care ultrasound should again be incorporated in this same arena as a tool and technology that can help us increase and improve our perioperative assessment and overall perhaps improve perioperative care. Many specialties have embraced the idea of point-of-care ultrasound, particularly within emergency medicine and critical care. Regarding the perioperative setting, emerging literature has demonstrated the utility of implementation of a comprehensive perioperative ultrasound curriculum and examination. One such examination is the Foresight examination, which I was a part of developing. The Foresight examination was a fundamental concept to embrace the idea of point-of-care ultrasound in its entirety and evaluating how it can improve perioperative care by designing a curriculum that focused sort of a head-to-toe approach on what components of point-of-care ultrasound would be relevant to improving perioperative care. Specifically, we focused on cardiac, pulmonary, hemodynamic, abdominal, airway, vascular access, and neuro as the main topics that we wanted to evaluate how point-of-care ultrasound could be useful. From there, we developed this curriculum here of Foresight, standing for POCUS, Perioperative Risk Evaluation Sonography, involving gastroabdominal, hemodynamic, and transthoracic ultrasound. So we developed this examination and curriculum, and implemented that to evaluate how we can provide a higher level of care for our patients. From this curriculum, we've been able to publish several studies on showing its utility. For the rest of this talk, I'll focus on one specific component or topic of this Foresight curriculum, specifically point of care airway ultrasound, and how point of care ultrasound can facilitate the identification and localization of the endotracheal tube within the trachea. Some more background. The use of the stethoscope to distinguish between trachea and bronchial intubation has been shown to be rather poor, with a sensitivity of only 60 to 65%. And let me try to highlight an example of that. Here is a recorded audio of a physical exam of auscultation exam of a patient, breath sounds after receiving an endotracheal intubation. Here's the patient's left side. And here's the right. And I challenge most viewers to be able to appreciate any difference in the auscultation level of either side. In other words, it seems that the patient has equal breath sounds bilaterally, and this would be documented as a normal finding to indicate appropriate placement of the endotracheal tube. However, if we add ultrasound to this picture, here's an ultrasound examination, and we'll talk about the details of this examination in the future slides, but I just want to highlight again, even if you've never used ultrasound to evaluate for the lung, to evaluate specifically to see if appropriate aeration is occurring, you can tell that if one side, if you focus your eyes here on the line which is the lung pleura, if you focus your eyes here, you'll see that there's movement indicating appropriate aeration. However, if you look at this other image here of the other side of this patient's lungs, you appreciate that there's a difference here. There is no movement in this hyperechoic band. And again, we'll talk about the details of this examination in subsequent slides, but I want to highlight that just by doing the ultrasound examination, we can tell that there's a difference between one side versus the other, something that was not appreciated when we did our auscultation examination. Specifically, what we're looking at here is the lung pleura line, and we're seeing the sliding effect of the visceral and parietal pleura as the lung is expanding in an appropriated aerated lung bed, comparing the other side here where we are not appreciating lung sliding or that visceral and parietal pleural sliding motion because of the fact that the aeration to the side is different or poor. And again, we'll talk about this in further detail in our subsequent slides. So there has been evidence in the use of point-of-care ultrasound for the identification of esophageal versus tracheal intubation, with a reported sensitivity and specificity of 100% for adult patients in the operating room, and a sensitivity and specificity reported there for patients undergoing cardiopulmonary resuscitation. In fact, the American Heart Association has now updated their guidelines to include ultrasound as an adjuvant tool to confirm correct endotracheal tube position when CO2 monitoring is not available. So there has been literature to support that ultrasound can be useful in determining esophageal versus tracheal intubation. However, I mentioned earlier on in the first part of this talk that there is a multitude of technologies available that can help facilitate the appropriation of the appropriate position of the endotracheal tube, esophageal versus tracheal. How about, however, the use of ultrasound to determine the appropriate location within the trachea itself? We designed an examination using two components of airway ultrasound to evaluate if point-of-care ultrasound can be used to help facilitate determining the appropriate location of the endotracheal tube within the trachea. The first technique was the lung sliding sign. So the lung sliding sign, I already highlighted it briefly in the prior two slides, is the phenomenon of looking at the back and forth sliding motion of the parietal and visceral pleura as the lung receives aeration. When you appreciate this hyperechoic line here, here's a rib, and there's another rib, and there's the lung pleura. When you appreciate the sliding motion of the visceral and parietal pleura sliding across each other, that identifies that, in fact, that you have appropriate aeration and can help distinguish esophageal versus tracheal intubation by looking for inaccuracy of or absence of this lung sliding sign. However, while this technique has been demonstrated to be potentially detect appropriate aeration to one side versus not receiving aeration, meaning the esophageal intubation, reported showing here actually of 89%, it's still looking only at the lung sliding sign would not help identify if the endotracheal tube is at risk for a bronchial intubation, i.e. is the endotracheal tube too close to the carina. From that standpoint, we designed a second component of our ultrasound examination. We abbreviated our examination the PLUS examination, standing for pulmonary and lung expansion ultrasound. Because of the fact that we knew that patient movement has been shown to cause significant position changes of the endotracheal tube, it's important to verify its appropriate location within the trachea and have a real-time modality to evaluate its appropriate placement. As we know, as I highlight, that this can readily change in the perioperative setting. We actually conducted a double-blinded randomized study to evaluate the ability of this PLUS examination to accurately determine tracheal versus bronchial intubation and determine appropriate location of the endotracheal tube. After patients were enrolled and consented, the patient would receive a standard endotracheal tube placement with standard procedure as it's routinely performed. But then a blinded team would then, after the patient was randomized, fiber optically guide the endotracheal tube to either remain in the trachea at the appropriate position 2 centimeters above the carina, or go into the main stem of the right or left side. After that placement occurred, we then had blinded auscultation and then interpretation of where the endotracheal tube placement was, followed up by a blinded point-of-care ultrasound exam. Finally, the tube was inserted into the appropriate position under fiber optic guidance. The specific ultrasound examination we used was a two-part exam. We first looked for the concept of tracheal dilation. So we placed our ultrasound probe. This is a high-frequency ultrasound, linear ultrasound probe, approximately 2 centimeters superior to the suprasternal notch. And we scanned craniocaudally up to the cricothyroid membrane. So from the suprasternal notch up to the cricothyroid membrane, we would scan transversely, and we are looking for tracheal dilation with the endotracheal tube balloon receiving inflation and deflation of the cuff. So while we are examining, scanning up from the suprasternal notch up to the cricothyroid membrane, we are inflating and deflating the cuff of the endotracheal tube to evaluate for this phenomenon shown here, of looking specifically at the trachea and the diameter of the trachea to see if we notice an alteration in the trachea from cuff inflation and deflation. By appreciating the inflation and deflation change, that told us where the cuff of our endotracheal tube was, meaning that at the ultrasound plane level where we identified this alteration of the tracheal dilation from inflation, that told us that our cuff was there, and i.e. indicating our appropriate position of the endotracheal tube. It was the absence of tracheal dilation that would trigger us to be concerned about potentially having the endotracheal tube at the level of potentially being close to a bronchial intubation, meaning within 2 centimeters of the carina. Specifically meaning that if we are not able to scan from the suprasternal notch up to the cricothyroid membrane and identify this phenomenon of tracheal dilation, that would trigger the next component of the examination and evaluate for pleural sliding. So both components were performed for the study. However, the logical methodology we had was first examining for tracheal dilation and then evaluating for the phenomenon of pleural sliding. Again, we used for the second technique here, we used a high-frequency ultrasound probe. We placed it vertically on the anterior chest in between two ribs, identifying the most anterior aspect of the patient's chest. For our standpoint, we placed it in mid-clavicular line, approximately third to fourth rib space, again identifying the most anterior aspect of the patient's chest. You can show here a demonstration of how we had the ultrasound probe placed to evaluate for this phenomenon of lung sliding. Here's an examination here of a patient again who had a positive lung exam, where we see again the lung pleura line here moving, indicating that the visceral and parietal pleura are sliding across each other, indicating again appropriate aeration of the lung tissue. We would use M-mode modality, ultrasound modality, to identify this motion artifact. So M-mode again is a dagger of ultrasound over time, and so by placing this ultrasound beam over the lung pleura, we would detect for motion artifact, which is shown here. The presence of this motion artifact would indicate again that we have appropriate lung sliding. Compare these top pictures to the bottom, in which we still identify this hyperechoic pleural line, but we are not seeing any sort of motion or sliding artifact. And if we again use the M-mode modality, we can see that the motion artifact is actually disappeared, and what we see is the classic termination of the barcode sign, meaning that we show continued horizontal bands, not indicating any motion artifact because there is no motion artifact, indicating again absence of lung sliding. With the focus again being here on the lung pleura shown here. So our results, again, we randomize our patients to have the fiber optic guidance of the tube being in the main trachea, right or left main stem, compare auscultation to the ultrasound examination. Auscultation showed a sensitivity and specificity of similar to what has been reported in the literature of 66 and 59% respectively, while the ultrasound exam showed a sensitivity and specificity of 93 and 96% respectively. We had several limitations to the study. The study utilized only 3 attending anesthesiologists to perform the ultrasound examinations, who had each performed over 50 ultrasound exams specific for this study. In addition, we are currently evaluating the utility of training and applying this on a larger group of anesthesiologists. Also, because of the fact that we were trying to evaluate the utility in a created scenario of intubation, we randomize our patients to have main stem intubation at a dramatically higher rate, 64%, than what is expected in the actual clinical occurrence. So again, the evaluation of the clinical utility of this modality, given the fact that we know that the main stem or bronchial intubation rate is much lower, it has to be taken into account as well. Finally, we did not evaluate the PLUS examination on patients with a known difficult airway or with known pulmonary pathology. This was simply because of the fact that we did not want to compromise any situation where oxygenation may be a concern, and we did not want to incorporate that confounding variable when we were first initially doing the evaluation of the utility of this examination. So to review, we talked about the utility of point-of-care ultrasound and how perhaps it can be implemented in the perioperative setting. We then approached one specific topic of the airway pulmonary ultrasound examination, specifically looking at placing the high-frequency linear probe in 2 locations on the patient. It is a 2-part component study looking for the identification of the appropriate location of the endotracheal tube. Those 2 parts of the examination for this PLUS examination study include, first, tracheal dilation examination, so placing the probe transversely 2 centimeters above the suprasternal notch, scanning up to the cricothyroid membrane, and looking for the dilation of the trachea upon inflation of the balloon cuff of the endotracheal tube. So again, what we're seeing here is dilation of the trachea as the cuff of the endotracheal tube is receiving air. The second component of the lung examination study or exam is evaluation for pleural sliding. So here, placing the probe approximately third to fourth rib space, mid-clavicular level, in between the ribs, looking for this phenomenon of the visceral and parietal pleural sliding across each other, looking for the presence of pleural sliding, was the second component of the exam. Hopefully, I've been able to highlight the potential use of point-of-care ultrasound as a highly accurate tool to determine the appropriate endotracheal tube position, and however, indicate that further investigation is going to have to be evaluated to evaluate the utility of point-of-care ultrasound for the perioperative setting. And it's an exciting time for ultrasound technologies in the perioperative environment, because we really are now just gaining steam on evaluating how it potentially can be useful to improve perioperative care. I encourage all of you to learn more about perioperative point-of-care ultrasound by going on the Go Beyond the Block segment on the Sonosite's website. Thank you very much for listening to this recording and the interest in perioperative point-of-care ultrasound.